have some exciting conversation going on. And Sarah, you have a special guest returning again. Do you want to introduce him and then we can jump in and start talking?
Absolutely. So, Mick DeAngelo has joined us once again for episode 2 of our workforce management strategy series. So, hopefully, you are tuned in to episode 1. Certainly would love to hear your thoughts and feedback if you have it. On this episode, we're going to shift things a little bit from the first conversation. Specifically, we want to focus on some of the deeper issues that go into workforce management strategy. So specifically talking about recruiting, vacancy management, and resource planning. So not necessarily the fun, sexy stuff when you're talking about workforce management, right? Because this is one of those titillating subjects that just absolutely keeps people on their toes. But this really is more foundational in terms of when we're talking about where staffing issues come into play. We had that conversation last time, Mickey. People hear workforce management and assume it's staffing. And one of the reasons we're having this conversation is to be able to dig in and talk about how it's so much more than that. Just for anybody who may be tuning in for the first time, give us a quick little overview of you and why you're here doing this series with us.
Yeah, first of all, just thanks for letting me join the Cool Kids Club over here. I feel a little out of place. You guys are completely awesome. But my name is Mick DeAngelo. I'm Chief Outcomes Officer at Ango Systems. We are a staffing solution and partner of UKG's, soon to be Infor as well. Really passionate about workforce management. I grew up in the healthcare space over 20 years now, filling a ton of roles. And quite honestly, I'm really passionate about helping everyone realize the best potential in themselves. And to me, that's what workforce management in healthcare is about. It's first about patient care, helping patients be their best selves. But to do that, we have to make sure the people that are actually there to care for them are in the best position to provide the best care. And I think in today's environment, that's challenging. And I also think as an industry, we're behind on that. And so quite honestly, I join podcasts and hang out with you and all of our peers because I don't think the status quo is going to cut it anymore. And so I'm really passionate about having these discussions and challenging that status quo so we can find new paths forward and really do this with excellence and move healthcare in a direction where we can be a leader amongst all of the verticals and not a laggard.
I'm going to tell a little inside baseball here. So before we started filming, we were having a quick catch up in conversation, and Vince really facilitating and participating in the conversation in our first episode in this series. His background in retail has been so helpful, not just for this conversation, but frankly, I think on my own workforce management journey, because there are so many things that retail had to get very good at very quickly in order to meet the demand, be able to do what they do, that to your point, right, we run the risk of being a laggard in the healthcare industry because we've not been as quick to shift and pivot as some other industries have had to be. So, Vince, while I know you're definitely helping facilitating and frankly keeping Mickey and I on track so we just don't completely divulge down a rabbit hole for 3 hours, those insights I think are really meaningful as well, that hopefully people don't just take away a little piece of something from a healthcare perspective, but also those lessons learned from retail are really relevant here as well.
I appreciate that. But no, I probably do just as much to get you off track as I do on track. I'm saying, just be real.
Well, that's the beauty of workforce on deck.
Yeah, exactly. But we do tend to ramble over, for those who are out there first listening for the first time, hopefully not. If you have, go back, listen to other episodes. We do ramble around, but we always get to the point. So just follow along with this. It's a good conversation. On that note, while there's a lot of lessons to learn from retail and other verticals for that matter too, it's different in healthcare though, right? You're talking about skilled labor. You're talking about people with specific things that you need. And one of those biggest challenges to me is, planning for the vacancies you're going to have, because you're going to have them, and planning that strategy and innovative strategies quite bluntly to figure out how do you keep at the right pace of hiring and backfilling and growing. Look, I'm always on the other side of healthcare. I'm the one that's being served from a client perspective, and you can tell a tremendous difference when you go into an operation that is got their stuff together. and the people are happy, things are happening, everything's executed. And then you walk in the next one, right? And you're like, 3 hours later, you're still sitting there looking around at other people that are still sitting there with you going, what's going on, right? The care, something's not right. Something's broken. So understanding, let's get into this. So when you talk about understanding the workforce supply versus demand in healthcare, what are some of the biggest challenges that you see? What's the impact of what is the vacancy rate even, right? What is acceptable? All those kinds of things. So what are your guys' thoughts? What are the biggest challenges when it comes to that?
When we look at vacancy right now, I think recent studies were just released for 2025, and nursing vacancy is currently down 5% from the year prior. So we were running around 15% nursing vacancy. That was a big improvement from just post-COVID. And we're now sitting around nationally around a 10% nursing vacancy. Now, I think we see a little bit higher when we go to some other areas. Imaging is starting to feel a little bit. I think we're seeing it a little bit in procedure tech areas. And so we're seeing some spikes elsewhere, but nursing's doing pretty good. But I don't think that's universal. I was talking to one organization I live in Cleveland, and they were sharing their med surg service line is sitting at a 35% vacancy.
Wow.
Like, that's massive. And if you think about, you still have to give those people that are working to prevent burnout, you got to let them have time off, PTO. That sits around 20%. So you're looking at half of your staff that you need to give patient care aren't available.
And what's so interesting to that, with you talking about specifically the med surg vacancy, when you were asking that question, Vince, what was going to my head is the skill mix is one of the reasons that this is so complex, because it's not something to where, and I'll use a very generic example, right? You're running a bank and everybody's trained to be a bank teller. So if somebody calls out and if they need to work the window or they need to work, inside, people can flex back and forth as needed. There is a limit to how well you can do that within a hospital, particularly if you have not planned accordingly. And you have folks who only can work to the top of their license. And if all of your vacancy happens to be in the intensive care unit, where everyone else that you have in-house is med surg, who do not have the skill set, the licensure, the certifications to care for those patients, there's going to be a really significant failure to solve for that outside of hiring contingent labor, throwing bonuses at people, running the risk of burning out your staff. So it's one of those things where it's a body doesn't just equal a body in healthcare in so many instances. And as you talked about, Mickey, as imaging is starting to see, some of these impacts, or, surgical tech, things of that nature. These are things that require very specialized training, schooling, certifications, residency programs in many instances, where you can't just find somebody from another area who can help fill in for the day. And that's why I think, one, this conversation in general is so critical, because again, it does get down foundationally to thinking about resource planning and also how you're using the resources you have today and where you can get innovative to maybe stretch them a little bit more. But also, as we mentioned on the last episode, having to think long term and not just continue to be in a reactive firefighter mode of, oh, I happen to have an ICU vacancy today. What are we doing 2 years from now? Because now all of a sudden when it flops and that's an ER vacancy and you've got plenty of ICU nurses, but they don't have the PAL certification that's necessary to work in the ED, all we've done is we've flipped the problem on its head.
I think that's an advantage we see right now, particularly in the tech side of the world. Our HCM systems are really growing a lot more mature in creating career roadmaps and highlighting where those skill gaps are and building the opportunities in to give more cross-skilling, of looking forward and seeing that, hey, we need to get more ICU or we need more ED. But I'm not sure that most organizations are mature enough in their operations. While technology is starting to lead that way, I don't think most of the organizations, at least that I work with, are mature enough in operations to actually quite be taking advantage of all of that. And nor is their data mature enough to be able to do that.
So on that note, I want to kind of back us up just for a second, okay? And the reason I want to do this is you guys are getting into some of the innovative things and ideas on how to solve this problem. I think it's important for those out there in this industry to understand the impact it's having more than just the burnout and everything. Critical by all means. It's absolutely critical, and we see it happening. We experience it. There's other impacts, right? If you're down in one department, that slows things down throughout the whole strategy and process of the healthcare, right? And not only does it slow it down from an executing and delivering for your customer, well, I call them your customer, but that's a bad habit on me, right? They kind of are still, all right. I mean, they're be patient, but I mean, in reality, they're a customer as well, and you should be treating them so that they're a patient and a customer. But let's talk about it. It has financial impacts, right? If I have competition between two hospitals that are close to the same distance to me, and every time I go to one or take my kid to one, I have a bad experience, guess what? I'm going to the other one. And then you start getting into financial. There's other things that it impacts. There's a lots of. So where I'm trying to come from is there's a lot of impact if you don't address this and you don't start doing the things that we're going to be talking about. What's the other impacts it has to you?
Absolutely. When you think about patient throughput, right? So, I'm for somebody who's on the other side of healthcare, Vince, very astute observation to pick up on that, right? Because you're absolutely correct in all of the different areas where there's an impact. When you have a hospital that has to divert patients from the emergency department because they're boarding patients in the ER, because they can't move people upstairs, because they don't have patient transporters, and there's no EVS to clean the beds, there's a ripple effect of what happens there from a regulatory perspective of you now being on lists and radars that you don't want to be on, from an overall patient experience perspective. Outside of the burnout component, now we're talking about increased labor costs. Now we're talking about lack of reimbursements. Now we're talking about significant infection control, risks that we're inserting into the equation. So all of those different things where, as we mentioned at the very beginning, Mickey, this is not just about nurse staffing. People, and I'm just as guilty of it, right? Like that is a passion of mine my entire career, but this is so much bigger than just staffing nurses and making sure you've got the ICU, the med surge. It's to the level of if your EVS staff is impacted, if your patient transport staff is impacted, your imaging staff, all of those things can have a really, really negative impact. And if you're not looking at it holistically, even if nursing is everywhere it needs to be, you can still have a really significant problem and likely will. It's not a if, it's a when at that point.
I'm gonna take this and move in a slightly different direction, and you can throw tomatoes at me and yell at me for it, Vince. But we're classic for this. We already know that. When I think about impact too, the impact varies greatly based on if I'm looking at a rural hospital or a metro hospital. Your rural organizations are feeling this even worse. They don't have the same talent pipelines or the same talent pools available to them that exist. And so, and I bring that up because obviously in today's, when we think of the policies coming through and the impact we're expecting in our rural facilities, when we look at this component of recruitment and position vacancy, and we marry these things together, we see that in our rural areas, it might even be more critical. And to the reasons that we're talking about, we're not just talking nursing anymore. We really are talking this whole, all the different cogs that work in a healthcare organization to make it all work and come together. It's pretty intense. I'll share a quick story real quick, just I think it helped, like what I recently experienced. I think I shared last time I was on here. I had some health issues lately, and just this weekend I'm still having some of those. And so I was in the ER. I had to go back to the ER. I was sent to the ER. It wasn't just like one of those things. And it happens. I'm doing fine. Obviously, I'm here. Life is good, right? I sat in the waiting room of the ER for 7 hours. Now, this is a near 100 bed ER, and they were saying we don't have room. That wasn't true. When I got brought back, there were plenty of beds to be had. It wasn't a bed problem, and I knew it wasn't a bed problem. It was a staff problem. They don't have enough ED nurses for the influx of patients that was happening on a Saturday. And that was in a metro area ED.
Yeah.
What happens when we see that in rural areas and you have to drive hours to another ER? I could have driven to another ER 20 minutes away.
Yeah. All of the downstream impacts of that, right? You sat and waited 7 hours. Now let's think about the patients who didn't sit and wait, who otherwise could and should have been seen. Now we're talking on a global scale, and I won't go down this rabbit hole. I'm going to share this anecdote and we move on. But now we're talking about the strain on the larger medical system throughout the United States, because now we've got people who now they have to go get into their doctor. So Vince, when you're going to your doctor's appointment and you can't get in, or you're sitting for an hour and a half because now all these folks who had been sent to the ED and couldn't get in are now going here instead, we continue to exacerbate the problem because at the core, we don't have enough people in so many instances to take care of the people who require care.
You hit something there that resonates. I won't stand in line 30 minutes for a ride at Disney, much less am I going to sit 7 hours in an emergency room. Mickey, I don't know how you did it. I'd have been like, I'd have been home. But
I was close.
yeah. So one of the things I pulled out of what you two said though is there's not one strategy. There's not a simple button. And this is where I want to go here now too. I think you guys do too, is let's start talking about what the pieces of the puzzle are that everyone needs to be thinking about and looking at from an innovative perspective to figure out what the right strategy is for them. Whether it's a rural hospital, suburban, metro, all those different factors, right? Where there's, you have to figure out how do you survive and how do you actually excel in the confines of your environment and what you have to deal with. I get it, right? I mean, I come from a rural place and a rural place, yeah, we were an hour and a half from the next hospital. If there wasn't a doctor there, you're in trouble, right? I mean, it was a life and death type thing. So let's talk about that. Let's get into the strategy. What are some of the key fundamental things of where people should start when they start thinking about their planning, recruiting, and that whole aspect of managing their vacancies? What's the ground?
My mind first goes to long-term pipelines. I don't think we can start with what are your short-term recruitment strategies. I think we need to look at what are our long-term pipelines. And quite honestly, that means going back all the way to starting to gauge interest to those in high school and working with the career centers that where you have allied health and you have some nursing things where you can get start there, like start building your pipeline all the way in the beginning. You build your pipeline with nursing schools. I think we have to think more long term to begin that in the process. And then the second point I'll make before I let Sarah jump in is I think we also need to look internal to ourselves and say, what career advancement, what training, what partnerships do we have for your EVS worker who's now been in the hospital and is like, man, I really see this and I want to become a nurse. And how are we advancing a career for our internal people and making it possible? So how are we building multiple pipelines that will feed us for decades, not the next 6 months?
So before Sarah jumps in, I got one question there. I'm putting myself in the position of someone in administration in a hospital. You said, look at my long-term pipeline. I got a problem tomorrow. Why am I worried about my long-term pipeline? I mean, I get it, but how do you respond to that? I mean, you got to take them through of, look, you have to take a step back, right? So lead me down that trail.
I think it's obviously a both and. You have a problem tomorrow because your predecessor didn't think a decade in advance, right? And so are you going to leave the same problem for whoever replaces you, or if you're still here in a decade? It's a both and. We have to both look long term, and yes, we have to find ways to strategically meet and creatively meet our immediate needs. I'll hold
So
there.
what I hear you saying is, if you don't do both, you're just going to be repeating solving today's problem over and over and over and over,
Isn't that
right?
what we've been doing?
Yeah, exactly.
And
So
why on earth haven't we gotten a different result? This is crazy. We keep doing the same thing. What's so funny is, and obviously you all are listening to us, but we're staring at each other. And as soon as Mickey started talking, I was like, God, he stole my answer. But my response, so Vince, you're spot on, because my response was then going to be Mickey's looking, almost, I don't want to say backwards, but Mickey's looking to the left of how do we build the pipeline? How do we start them young? How do we, kind of build those relationships? My answer was going to be we need to also be looking to the right and not thinking of what do I need today to fill my shifts, but what does my organization look like 5 years from now? What is my business strategy and how am I developing a retention and recruitment plan that aligns with that strategy? Because otherwise, the tomorrow they're worried about right now very quickly turns around and now all of a sudden it's tomorrow 2 years later and you're kicking yourself because you didn't take the opportunity to do it when you had the chance. And it's this perpetual cycle that continues to happen because there's this expectation of like, okay, if I do this one thing, I'll solve for it. It truly is, as you said, Mickey, this both and thing that has to be looked at holistically in order to not continue to be on this Groundhog Day.
So, Sarah, within that, would you also consider reevaluating the skill mixes that exist within units and within your care coordination?
Oh my gosh, yes. And I'll tell a quick little personal story here. Right out of high school, I was a medic in a level 1 trauma unit and out of state. So I was not in the state of Florida. And the working to my license then in Tennessee, and granted, this was quite a few years ago. I'm not going to say quite how many, but enough that it was impactful. Working to the top of my license there, working in level 1 trauma, putting in IVs, extubating patients, all of the things that I was able to do. I moved back to Florida and they said, hey, you can be a CNA and you can empty bedpans. And if you're lucky, we'll let you take our phlebotomy course and you'll be able to draw blood. And I said, what? No, I'll go into leadership instead. Like, no, like I need to be in it. I'm not going to work that far beneath my license and my skill set. And that is why it's been something. So as you're talking about, right, these training programs, how do we take people from EVS who say, I want to be a nurse and we build them up? That's been such a huge passion of mine and something that I talk to customers about all the time because you are losing a significant portion of people who, one, have the desire, the interest, and frankly, most likely the ability, but also losing the chance to build that long-term loyalty and sense of ownership in an organization because you invested in them. And it's mutually beneficial, right? At the end of the day, we get somebody who has a slightly, greater skill set. Maybe they're not going to be an RN. Maybe they go through an LPN program. Maybe they go through an EMT program. But it's providing additional clinical resources in the areas where it's needed most. It's building, again, that loyal fan base of employees who are going to continue to grow and shift with your organization. And it's being innovative and creative about the ways that you let them work to the top of their license and the care they're able to provide and the tasks they're able to do outside of this outdated model of, and we talked about this a little bit last time, I work 7A to 7P and these are my tasks and this is what I do. Who can potentially pass your meds instead? Who can take out your IVs? Who has the opportunity to do XYZ things? Let's identify what those areas are. Let's see our population and let's train to it so that we can self-sustain. Even if the nursing schools, the radiology schools, the vocational academies don't continue to churn out the level of people that we need, it's okay because we're continuing to build and evolve our own internal team of folks who can take care of our patients and get the job done.
Love it.
yeah, super quick recap here. So we talked about the fact that people need to look at the long-term and their short-term strategy, basically look at, out and, or however you termed it. And Mickey, that was perfect. But we also talked about you need to be evaluating what your skill matrix is while evaluating how do you continue to grow people and experience people and invest in people. Um, you know, there's reasons that the healthcare struggle with this, right? And it is challenging, right? What would you say the biggest reason that a lot of health organizations are behind the curve on this? Is it they don't take the time to do it, that they're so busy just keeping the wheels on the bus that they're not actually doing the oil changes and investment into the what they need to be doing? Bad analogy, I know, but you get the point, right? What is it that's stopping them from doing this?
I think part of it is that very dangerous mindset of this is the way we've always done it, and
Hmm.
this is the way it's done. And zero fault to any administrator or healthcare leader who's in that boat, because I've been there. I have been a clinical manager who was beholden to my organization's processes and policies and lack of governance that allowed for those things to be changed easily on a dime when needs shifted. So sometimes you just continue to do what you've always done because that's the only thing you're able to do. And not having access to conversations like this, very candidly, again, it goes back to why when Mickey and I first started talking about this series, it was so important. 20 plus years ago, when I started my clinical career, didn't have a podcast, a TV show, a magazine, a newsletter that I could turn to where people were talking about these things. So you learn through trial and error. You hopefully build a network where you talk to other people and you get some ideas. But we've got to focus on expanding the messaging and building all of these folks access to this information so that they can bring things back. They can innovate. They can try new things, because right now all they know is what they've always seen. And if every other hospital is all doing the same thing, how does anybody get better? Because we're just continuing to perpetuate the problem over and over and over again because what we see is what we do.
I can say, I love that, right? And it goes back to that element of innovation, which is where, Mickey, you started earlier, right? You started going down this channel of innovation and technology and information and doing something with it. Not to harp on retail again, but you want to talk about innovation. If retail wasn't innovative, they'd be dead already. Amazon wouldn't exist. You wouldn't be ordering toilet paper today and getting it this afternoon. Um, you get my point, right? I mean, innovation has to be a key element. A lot of organizations also haven't made the investments to do that. They're still living off of paper or some anecdotal system, to try to drive and understand what their labor is. What are some of the things that organizations need to start putting in place to make sure that they can do this long-term planning on top of building the strategy around how to develop people? They got to be able to get to that information and know what are the right people to develop and build out that plan and strategy. What are some of the key things and innovative things you guys have seen and recommend for them to do as steps?
I'm going to answer both your last question and this one simultaneously.
Yep.
So it's like magic.
Awesome.
Um, we're really talking about roles that fall within the CHRO at this point, right? These are primarily HR functions when we're talking about recruitment, building pipelines. But we think about the role of the CHRO, it has moved from a tactical execution style, that's what HR is, into a strategic, how do we achieve business outcomes? Like that transition's happened pretty quickly over the past 5 years or so, maybe even a little bit more than that. And Sarah, I think you made the statement earlier. We see some organizations that really have adopted a strategic HR partnership, and really where the CHR is a strategic part of the C-suite and not just this side thing of HR. We have to make sure we have compliance and stuff like that. But we haven't seen that across the board. Like our major enterprises, we see that, but we don't necessarily see that in our community hospitals and things like that. And I think for me, that's the key to even the second question. I think it answers to why we've had some problems, but I also think it comes into how do we solve for this? It's by lifting HR and making them that strategic partner and partnering them with your CFO, your COO, to understand what these global issues are and tackling them holistically together. Because obviously when we're talking about this, we're talking about just the front door. Well, there's a back door of we're losing people. What is it? 30% of new hires are gone within the first year.
Yep.
Like, it's part of this equation too. And that falls within the CHRO partnering with all this. And so it is a very complicated, large item that I don't think to me, it always comes to governance structure, but I'm coming back to it again. It needs to be this collaborative item that the CHRO is working with their partners to holistically look at this and solve the problems. You're not going to do it without your CNO at the table, for example.
And I think, one, I 100% agree, but also the reality is, which a lot of places don't want to hear, you have to make the investment because you're spending the money regardless, whether you're spending it on investing in a long-term strategy, or you're spending it on contingent labor, or you're spending it on regulatory fines that you get because now you've got unsafe, staffing ratios, whatever the case may be. We know that the cost is associated somehow, some way down the line. So would you rather spend the money because now you've been hit by Joint Commission and you've got, red flags on your record and your Medicaid reimbursements are being impacted? Or would you rather invest in reaching across the aisles to your partners in HR and saying, hey, you know what? We should develop a nurse intern program where we can take people from the local community colleges. We can identify them as new hires before they even graduate. We bring them in. We've got an orientation plan. Here's the upfront cost that's going to take, but here's the downstream impact that we're going to have from that, which is a constant, steady stream of staff who may not necessarily, all wind up on the ICU, but it gives us the opportunity to continue to have people coming into the organization where otherwise we wouldn't, where frankly, we would have been spending money on agency staff anyway.
I freaking love that. That is so dead on. I'm going to take that and I'm going to apply it in a different manner, though. When we think of the technology systems that support all of this, what do organizations do? They spend millions of dollars. We're going to get the best WFM system, the best HCM system, the talent. We're going to do all that. But then when it comes to actually administrating it and utilizing all of its opportunities, we're going to run a bare bones ship. We're not going to invest into, and so we end up using it to 20% of its capability, which is part of why we have all this rich data available to us, but we don't have teams to be able to access it and understand how it impacts our organizations. Because we haven't, to your point, is taking that same investment thought and applying it in the terms of the technology. We haven't invested the money to actually leverage it to actually see our outcomes.
So what you're saying is they're buying Ferraris and driving them like Buicks. So
bingo.
Yeah. I love
right.
the way you boil it down. That's awesome.
Yeah.
So
I spent $1 million implementing best-in-class technology because we're going to solve our recruitment issues. We're going to solve our staffing issues. But I'm not going to spend the $30,000 over a multi-year, deal to bring in add-on technology that lets me get it 100% of the way where it needs to be, or lets me take out some of the manual components, or lets me solve a problem that all the bells and whistles on that Ferrari, for whatever reason, can't handle for me. And this one little tiny piece that will get me there, we've spent the money already. We know we're not going to invest in training our resources. We spent all this money on the product. It's not being able to see long-term down the line of how close they are to the finish line, and then they just kind of throw their hands up and walk away.
I'm going to tell it. So I just met with an organization last week. I'm not going to name their name. They were in the news, but they had some layoffs. They're getting ready to do a WFM implementation like in the next 60 days. And they're doing an HCM implementation and ERP implementation next year. Of their layoffs, they laid off all of their change management personnel. That is the most short-sighted. We want to save. Now, they needed to save money, and there's good reasons they needed to save money. That is not going to get you where you need to go, though.
No,
it's not. It's not. And look, there's lots of ways to get the right money in the investment. It's always investments in the right places always pay off, and understanding that is where I think a lot of organizations struggle. I mean, you threw out that 30%, turnover rate, people leaving in the first year. I'm like, man, just cut that in half. And you probably just saved enough money to pay for any major initiative when it comes to technology and insights and AI and everything else to help make you more successful. It's kind of what I see in a lot of organizations, and you said a little bit earlier, Sarah, that people just want to do it the way they always done it. And a lot of times too, I think they want to do it the way they've always done it, but it may be that they don't even know what else is out there, right? It's not necessarily they're not even open to change. It's that they haven't, again, I think I said this maybe last time, they haven't looked over the hedge to see what the heck's going on and to know, oh my gosh, I could do that and it would help me solve all these problems. So I think being open to things like we're doing right now and looking at innovation will help tremendously, but don't be afraid of it. You gotta do it at some point, or your future is imminent, and it's not good. Um, all right, so you got me convinced. I got to make the investment. I got to look at the short term and long term. I need to look at my technology. I need to look at the skills. I need to look at the strategy of upskilling people. I need to do all these things. Um, what are some things I shouldn't be doing? What are some things that look good on the outside of solving a problem right now, but might actually hamper what I'm trying to do in my long-term strategy?
That's a good one.
Yeah, I'm thinking on that one.
This isn't really earth-shattering, but I would say the first thing that comes to mind for me is don't be so focused on what you're doing in the future. How can I get this staff, that you lose sight of the people that you have now? And it goes back to what we talked about before, whether it's upskilling, it's, offering programs and giving people a reason to stay. I see it so many times that you're so focused on recruitment that you forget about retention. And that's a really key piece to this strategy in general. When we're talking about literally the topics that we're meeting here about today, I don't have to worry as much about vacancy management if my people aren't leaving. But if I'm throwing a whole bunch of money at new hires, so the nurse who's been here for 20 years who needs to train them all is making $15 less than the brand new grad who's walking in the door. If I am putting out all of these programs and offering these new, sexy benefits to get people to come in, and I'm not extending those to people who are legacy within my organization, I've now taken a problem and exacerbated it, because now as quickly as I'm trying to pull people in the door, I've got people who are walking out and going down the street to the next city over to the organization who is thinking about those things. And that for me is something that I see every day, because again, not taking a holistic look at the problem and instead only trying to fight this one particular fire. And as a result, you start three more.
I think I'll take a little bit of a different direction in answering that question. We've really talked a lot about the HR side of this. Let's talk a little bit about the finance side of this. So even before we come to trying to fill positions and vacancies, we have to create budgets, right? We have to determine what our matrices are and what our annual FTE budget is going to be. And what I think when I think of the question, I think we can't be afraid. Like, change is hard, and particularly and change is especially hard when we're trying to execute change with a finance team. But the calculations we use to determine FTEs are too often glorified spreadsheets, first of all, and they don't incorporate everything we need. We need to be able to goes back to my first item I said, we have to challenge the status quo and look at how we even determine that, to make sure that when we're hiring positions, are we hiring the right amount positions? Are there the right amount of open positions? And there's some simple things that I know are not taken into account in most organizations. Like, we put out an FTE count, for example, and we say we need 50 nurses, we need 50 FTEs on a unit to be able to meet our average daily census. Now, I could go a whole lot of different directions of how I think that average daily census is a good item, but it doesn't paint a full picture. I'm not going to go down that path. But let's paint a picture that something you probably know, Vince, from the retail side, and I certainly know from my 5 or 6 years in healthcare call center management, that most of our nurses are at 0.9s. They're not at 1.0s. That calculation assumes everyone's a 1.0. Well, to fill the same number of shifts with 0.9s versus 1.0, I actually need more FTEs. Or do we actually, a lot of times we fold non-productive time and we will bolster that up, but we actually don't do calculations to really understand what is our non-productive time. I talked to one organization that said, it goes back, their PTO utilization was 22%, just PTO, not talking leave of absence, not talking absenteeism, just PTO, 22%. Their non-productive bump they gave in hiring was 10%. Well, you're 12% behind when I talk only one other metric. And so
you hit the nail on the head, right? I mean, in the world of retail, I mean, I'm going to equate this to scheduling, right? And forecasting. If you predicted your schedule needs within a 90% accuracy, you were fantastic. Fantastic. So what does that mean? That means you are overscheduling at times, getting into your non-productive, and you're potentially underscheduling at times. You can't do that in healthcare. You cannot do that, right? You got to have that max. You got to, so to your point, you got to slightly over hire based off of some of those metrics that they're looking at to be able to actually be suffice on the customer or the patient experience you're trying to deliver. The other thing too is I think people look way past the cost of losing a resource. Retail, you ran 100% a lot, right? A lot of organizations ran 100% turnover. The cost of investment, you may go, well, that's probably pretty low. No, it's not that low, because when you look at what it takes to hire them, the people that's recruiting them, the people getting on board, there's a cost there, right? And they figured out it was about a 6 months worth on average of cost for a resource every time you lost one. And if you don't focus on that retention, focus on those things and all the pieces you guys put together there, right? That needs to go into that financial element. Is it worth paying people $5 more an hour to improve retention versus all the money that's going out the back door to actually go get someone and get them trained and get them on board? Yeah, it probably is, right? They have to be analyzing and looking at that of where is it best to spend the money to improve some of those pieces of the puzzle to, and that's a long-term strategy as well, right? You can't just go out there and all of a sudden start paying a lot.
A lot of it has to do with schedule flexibility. We pay, safety is a big deal right now. How are we investing into the safety of our clinicians? Actually, studies have shown there's a whole lot of things before money that our clinicians, not just nurses, care about in terms of staying in their position. But are we investing in those areas or are we not? Is the question we've been asking this whole episode.
Awesome. Well, hey, we are coming up on time here. This is, man, I mean, we got like 20 more questions we never got to. So
shocker.
Tune in for number 3. But as we close out here, I give both of you guys the opportunity, if nothing else, what are the top 2 or 3 things that you want people to walk away from this podcast with?
Innovate. Talk to other people. Hear what they're doing, be willing to try new ideas, and what got you here won't get you there. So I'm stealing that. That's a famous book, one of my personal favorites. You have to be willing to think differently if you want different results. We said it at the very beginning, us continuing to do the same thing as an industry and expect something's going to change is just going to continue to bite us. And we've got a whole new generation of workers who are coming up who are not going to tolerate and abide by the old rules and the old ways of doing things. So you get on the bus or you get run over by it.
Well, okay, Mickey, you tell me how to avoid getting running over as well.
Don't get run over because you'll sit in the ER for 7 hours before you get treated, Vince. So don't recommend it.
In the ER. That was in the ER waiting room.
Oh,
I literally was only in the room for 20 minutes. I think if I was to think of takeaways, oftentimes in the WFM world, at least, we spend so much time talking about scheduling and staffing and all that. However, when I look into why we have so many open shift vacancies, not position vacancies, it has to do with all these upstream things and organizations not understanding that there is a cohesive flow from the beginning of this journey, from how we're determining FTEs to being able to calculate our position vacancy, to our non-productive time. Like, all this stuff works together and feeds into how we actually create schedules and how we staff. And so one of the things I want people to walk away from is, you got to understand the impacts on this part of the journey if you're going to fix this other part of the journey. And that it comes into the same thing I think we've talked about in other episodes. There's a lot of rich data that points to how we solve and what we should be doing. We have been doing emotional-based reactions as an industry for a long time. The data's there. Let's use it to drive our behaviors. And so let's actually dig into the data. Some of the data points we discussed today, some we didn't. But there's a lot of data that unpacks that we can start solving for one piece at a time.
I love it. I love it. And what I hear you say is, I mean, it sounds, so many organizations don't understand their entire process from entry to exit, right? And a lot happens in that journey as an employee, and we got to understand that so you can map out the whole flow and tie it all together, right? Anyway, those were fantastic takeaways. So I hope, just rewind 30 seconds, maybe 2 minutes. Sarah got carried away there. Just kidding. And write down those points and put those to memory and start executing on them. That's our ask. Don't just listen to us. Put this stuff into play. Sarah, Mickey, I want to thank you guys. Another great episode. I'm looking forward to number 3 already, and we'll keep diving into this healthcare sector even more. I love it. Thank you both.